Okay, so good afternoon, everyone, and welcome to this Africa PCR webinar. It's number 4 in the 2022 series, and the webinar this afternoon is entitled "How Should I Treat a Patient with Pacing: A Patient's Journey?" And we've got some excellent discussants from Egypt and Kenya. The learning objectives of this afternoon's webinar is as follows. Number 1, to explore a patient's journey from first medical contact to cardiac resynchronization therapy for heart failure. Number 2, to discuss regional variations in access to CRT implantation. And 3, to discuss the basic implant techniques of CRT implantation. My name is Ashley Chin. I'm a cardiologist here in Cape Town, South Africa. And it's a great pleasure for me to have 3 colleagues from Egypt and Kenya. Dr. Omnia Kamel is from Aswan Heart Center in Egypt. Dr. Mzee Ngunga is from Aga Khan Hospital in Nairobi, Kenya. And Dr. Mohammed Jaylan is also from Aga Khan University Hospital in Nairobi, Kenya. So welcome everyone, and I look forward to this webinar this afternoon. So we're going to kick off the webinar this afternoon with a case presentation, and Dr. Omnia Kamel is going to present a case that requires a pacemaker. So over to you, Omnia.
Okay, good afternoon, good evening, everyone. It's my pleasure to be here in Africa PCR webinar. It's me, Omnia Kamel, the head of a cardiac pacing and electrophysiology unit in Aswan Heart Center. We will start our case today. He is 50-year-old male patient, smoker, hypertensive. He is from Aswan. The patient at the age of 15, he complained of shortness of breath, and at this time he was diagnosed to have chest infection and received antibiotics with partial improvement. However, after 2 months, he was admitted to a nearby hospital by heart failure symptoms, where he was diagnosed to have rheumatic heart disease with severe aortic regurgitation. The patient was discharged on oral anti-failure treatment, including diuretics, ACE inhibitor, and long-acting penicillin. However, the patient was not compliant on his medications. Over the following 2 years, the patient was admitted twice with impending pulmonary edema. That's why he was referred to another hospital in Cairo to have aortic valve replacement. He was scheduled for surgery, but due to the very long waiting list, he had the surgery after 1 year. At this time, his ejection fraction was around 50%. After the surgery, the patient was kept on anti-failure treatment, but he was not well compliant as he was almost asymptomatic. After 4 years, the patient had recurrent symptoms and diagnosed at this time to have severe mitral regurgitation for mitral valve replacement with well-functioning aortic valve prosthesis. However, the patient was afraid from the surgery, that's why he refused. But due to the recurrent symptoms and the recurrent hospital admission, the patient, after 1 year, agreed to go for the redo surgery. After the surgery, his ejection fraction dropped to around 35%. He was kept on anti-failure treatment with poor compliance, and then at the age of 48, the patient was presented with progressive heart failure symptoms and recurrent hospital admission, and at this time his ejection fraction was around 15%. Actually, he was scheduled for coronary angiography to exclude any significant coronary artery disease, and the coronary angiography revealed normal coronaries. That's why he was referred to our heart failure clinic in Aswan Heart Center for assessment. The patient was presented to heart failure clinic and has had functional assessment and the new echo, which confirmed the severely impaired ejection fraction, around 15%, and he was kept on anti-failure treatment, ramipril 1.25 milligram per day, carvedilol 6.25 milligram per day, spironolactone, and exomide, but unfortunately he couldn't tolerate any up titration of doses. This was his ECG on presentation, revealing left bundle branch block with first-degree heart block. And thank you very much.
All right. So, I mean, thanks, Omnia. Thanks for that presentation. So, yeah. So the webinar is divided into two parts. We're first going to concentrate on the time of for the patient from the time of presentation to the time of first contact, and then referral to a tertiary institution. So, I'm going to ask at this point. Dr. Mohammed Jalen, just in terms from Kenya, just on some of the similarities and maybe the differences with respect to this case. How would you have managed this case? Or in other words, how would this case be managed in Kenya? And are there any similarities or differences that you can see?
Thanks, Professor Chin and Professor Omnia. This is an excellent case, and it kind of highlights a few things. One of the things I'd just like to focus on at the moment is the fact that this patient presents with heart failure. And when we look at the various etiologies of heart failure in Africa, particularly in our country, in Kenya, rheumatic heart disease remains an important cause of heart failure, even if we're dealing post-valve intervention with systolic heart failure. But there's some things that are pertinent to this case that I think are also relevant across the continent. The first thing maybe to emphasize is the delays, first of all, in treatment that may have occurred in Kenya, for instance. The diagnosis of rheumatic heart disease, or certainly of rheumatic fever, and partial treatment with antibiotics can be a bit of a concern. So at that first primary contact with a clinician, there's a concern around making that initial diagnosis of rheumatic fever. Once the diagnosis of rheumatic fever has been made, access to echocardiography in patients who present with symptoms and trying to connect the symptom of heart failure, which can be quite insidious and can be similar to the presentation of other tropical diseases, can be a challenge as well. So access to echo has been really emphasized in the last, say, 5 or 6 years with an approach to improving access to echo by allowing people who aren't necessarily cardiologists or indeed echo technicians to develop the skill and make it accessible across the board. The other thing that springs out is the referral pathway. So there appears to have been some delay, and understandable, in getting the patient from the initial diagnosis of rheumatic heart disease to initial surgery and then subsequent surgery. So the referral pathways are, I would say, you either know a cardiologist or you don't, and there isn't as efficient a systematic process for creating the referral and getting the patient efficiently into either a public or private sector. Once you've identified a cardiologist and you can get in touch with them, most of us are pretty accessible, then you've got sort of 90% of the way there. And the rest, I guess, depends on the patient. And I note there was some delay because of fear of access of the actual treatment. And sometimes that fear in Kenya relates to two things. First of all, fear of an operation. The patient was concerned about having open heart surgery. And then also fear about the quality and the competence of the local practitioners and concerns around that. And we do have, from time to time, patients who leave the country and travel either to North America, Europe, or to the Indian subcontinent to access treatment. And again, this is partly because of misconceptions around the quality of care and the ability, because these are really technologically important interventions for a country like ours to be able to access that.
Yeah. Thanks, Mohammed. That was excellent. I mean, I just want to encourage the audience for audience participation. Please, we want to make this, please send your questions through to the chat line and we'll try our best to answer each one of them. Yeah, so I think you've spoken about, a sort of a universal problem where there's at least in Africa, where there's a delay to seeing a cardiologist. And then I think there's also specifically in South Africa, also there's a delay in then delay to cardiac surgery. And it speaks of the paucity of cardiac surgery that's available on the African continent. So I just wanted to ask maybe Omnia at this point, in terms of Is this a common finding in Egypt that a patient waits several years before he or she can have a valve replacement, or was this a particular about this particular patient and who didn't want surgery?
Okay, this patient started to complain actually like 20 years ago. At this time, there was no cardiac centers except in Cairo, almost no cardiac centers except in Cairo, the capital of Egypt. That's why this patient was from Upper Egypt, from Aswan, so he spent some time to be referred from Aswan to Cairo to be assessed there and then to have the surgery. Actually, you know that if you have few cardiac centers and few specialized cardiac centers, so the waiting list from other cities and villages will be large enough to delay the operations. That's why, yeah, at this time, there was an average delay to the surgeries, like maybe 1 or 2 or 3 years before the patient could have an access to the surgery. Now, due to the availability of more cardiac centers, we have now Aswan Heart Center in Aswan, and we have another cardiac centers in Luxor and whatever and so on. So we have many cardiac centers now in Egypt. So the waiting list is much lower than before. So the average waiting list for surgery now is around maybe reach to 6 months, maybe 3 months, and for the urgent surgeries, it could be done like within 1 month or within 2 weeks or whatever, according to the level of urgency. And that's why we are in Aswan Heart Center and other cardiac center in Egypt. We are classifying the patients depending on the level of urgency, and then we are give them appointments based on their urgency and level of urgency.
Okay. Right. Thank you. And Dr. Jalen, I just wanted to find out, I mean, what is in Kenya at the moment in terms of the waiting list for cardiac surgery? Are you also finding that there's a delay? You know, what sort of delays are you seeing in Kenya?
Yeah, I'd speak of the same issues that we're seeing in, you're describing South Africa, particularly in the public sector. So we are doing cardiac surgery in the Kenyatta National Hospital, in Eldoret now, and in Mombasa. And these are 3 centers that probably will do 1 or 2 operations on any given day, and probably 3 days of surgery per week.
All right, I just think we've just lost Mohammed for a short while there. At this point, I thought let's go to the. I'd just like to introduce a spokesperson today, Dr. Mzin Gunga from Kenya, and he's manning the chat line. And Mzi, has anything come through through the chat line for the discussants?
Hi, Dr. Chin. So very, very good, because someone is asking, George, is asking about this patient presented with symptoms from the age of 15, which is a kind of, I'm not sure if it's pediatric or adult. Different countries have different age limits for who sees who. George is asking,
in Egypt. Yeah, it's pediatric in Egypt because pediatric are below 18 years old. Yeah.
18, yeah. So George is asking about the role of SGLT2 inhibitors and nebulized inhibitors. If this patient has heart failure and you probably need to use these drugs, he has rheumatic valve disease, it is true, and he is waiting for surgery, or the patient requires surgery, or indeed, like in your case, the patient has declined surgery for whatever reason. Can you use SGLT2 inhibitors or nebulized inhibitors in this patient who is not yet 18 years? Because many of these studies that we are looking at are for adults. What is your thinking? What do you do in this particular scenario?
Yeah, actually, in this scenario, we can add it. It is as we know, we don't have strong evidence in such age for those medications, but by experience, we have good outcomes of this medication in the patients with heart failure. However, as I said, that this patient had this situation like 20 years ago. That's why it was is not available at this time. But nowadays in Egypt, because of the presence of insurance, we can give the patient such a medication. But its benefit is proved more in adults, as you know. But yeah, in some situations we need to add it. Yeah.
Okay, that's I think a very, very useful point, because kind of I'm not sure the experience of doctors using these drugs in people younger than 18 years, but I think it's a very, very interesting dimension as well. So that's the only question on the chat box at the moment. But just to ask again, when it comes to rheumatic heart disease, particularly patients who decline surgery, and of course they have symptoms. Do you have any experience, maybe Dr. Chin, Dr. Kamal, in your country about the use of these new agents in this group of? Do they improve symptoms? Do they? What is the role of this drug really in that group of patients? They are probably more in Africa, because Africa is where we have all this complex mix of patients. Do they have a role in this group of patients who? Because I also had a patient in our country who had rheumatic mitral stenosis, actually a lot of edema, and for some reason there was no surgery. And I found the patient taking an SGLT2 inhibitor, I think, before we sent them to surgeon. What is? Do they improve outcomes, or how would you answer doctors who are asking these questions? Should they be given, or should we insist on surgery as the best option for these patients?
I mean, I don't have I can't give a correct a straight answer for that one. I don't have experience with SGLT2 inhibitors in patients who refuse surgery. I mean, the mechanisms, the pathophysiological mechanisms that, to me, if it's mainly valvular, I think there may be a response, but the response will be less than someone who with an ischemic or a non-ischemic cardiomyopathy, just from from my sense. But I do, yeah, I think if you've got a valve, if you've got heart failure from a valve lesion, the treatment is to replace or you repair the valve, and all the remodeling medication comes secondary. But I won't be surprised if the SGLT2 inhibitors do improve symptoms. I'm not sure about outcomes, but hard outcomes, but symptoms in patients with heart failure. That would be my impression.
Yeah. I think the best option is a surgery for sure. But while we are waiting for the surgery, if the patient had heart failure symptoms, I think it's a line of treatment, but it's not, as we said, that in this category you couldn't guarantee the good response for it. But mainly in regurgitation, like mitral regurgitation, aortic regurgitation, and dilated dimensions and LV dysfunction, I think it may add some benefit as regards symptoms. But in patients with like severe mitral stenosis or with preserved function or something like this, so I think it's mainly dependent on the valve status. So I think it's hard to have a good outcome in those patients with medications only. So I think whatever the medication, diuretics or beta blocker or whatever, it will be like a only bridge, waiting during the waiting time for surgery, not a cure for the patient, because we know that if the patient have regurgitation lesion, and then the guidelines actually resetted the parameters for intervention to be lowered, so we have low threshold for intervention in such patients to avoid the remodeling of the ventricle, so you can improve the outcomes after surgery. But when those patients go for surgery with severely admitted ejection fraction, actually it is so hard for the reverse modeling to occur. So as early as we can to go for surgery in such patients, I think it would be better. But if you are waiting for some time and you have impaired ejection fraction, so you can try some medication to help your patient till the surgery time. Yeah.
I think once a patient has had their surgery, and let's say they have had their valve replacement, like this particular case, and they've had their valves replaced, and they're left with post replacement LV dysfunction, I think many people would give your standard HFrEF treatment and possibly include an SGLT2 inhibitor at that point. And as with LV dysfunction. And it's interesting because in the CRT literature, most of the randomized trials have excluded patients with so-called valvular cardiomyopathies, but there were a small percentage of them that had underlying valvular cardiomyopathies, and it appears that those patients appear to also benefit from cardiac resynchronization therapy. So I suspect that these patients need to be put on their standard HFrEF treatment for their LV dysfunction post valve surgery.
Thank you for that very interesting question coming here as well, Dr. Chin. Someone is asking, I think it's from Uganda. Given the prevalence of the rheumatic mitral regurgitation in this part of the world, and these patients come with a low EF 15-20%, for example, and also people who have primary cardiomyopathies, how would you differentiate if this valve is really the primary cause of the disease, or indeed this patient has a primary cardiomyopathy with secondary mitral regurgitation? For the referring doctors, what would you advise them to do when they get this kind of cases, when they're not certain about the primary cause of the disease, for example, in this, whether it's rheumatic or indeed just a primary cardiomyopathy, which is quite common again, we see it in Africa.
Right. Do you want me to answer that one? Or? Yeah.
Maybe Dr. Kamal can.
Okay. Dr. Kamal, you want to go first, and then I'll.
Yeah. Okay. So I think in such patients, the most important is to detect the pathology of the mitral affection. That's why the echo by an experienced operator is very crucial in differentiation, because when you see the echo, you can differentiate the pathophysiology or the pathology affecting the mitral valve. So if we found the mitral valve is thickened and leaflet and it's abnormal leaflet, so we can suspect of rheumatic affection. But the pathology in the primary cardiomyopathy, it is due to the annular dilatation of the mitral valve. That's why we can see a healthy mitral valve but with dilated annulus. That's why you can see severe mitral regurgitation. So I think by transthoracic echo you can differentiate easily. If it's not, you cannot conclude the pathology, so you can go for transesophageal echo. It will give you a better picture for the mitral valve, and you can see the mitral annulus clearly, and you can measure the mitral annulus and see if there any calcification favoring the diagnosis of rheumatic heart disease or thickening or commissural calcification. Those criteria are characteristic for the rheumatic affection.
Yeah, I agree. I mean, I think the echo is crucial here. I mean, clinically, you can also, if you have mitral stenosis, for example, if you've got rheumatic aortic regurgitation clinically, then it suggests it might be primary rheumatic mitral regurg, but it's not absolute, because you can get secondary mitral regurg. But I think at the end of the day, the echo, either transthoracic or transesophageal, is an important one, because you want to look at those valve leaflets very carefully to look for underlying features of rheumatic heart disease: thickening, calcification, commissural fusion. Looking at the other valves, sometimes looking at the aortic valve can give you a clue as well to look for any rheumatic changes there. So the echo is really your investigation of choice to distinguish between primary rheumatic mitral regurg from secondary dilated cardiomyopathy and secondary annular dilatation. Yeah. I don't know if there are any other questions that have come through at this point, or should we move on to the part 2?
I think you can move to part 2, as I'm sure we'll get more questions as we move along.
Okay, so I just encourage everyone to continue sending your questions in, and even if we'll come back to those at a later stage. So I'm going to hand over back to Dr. Kamal, who's going to tell us what happened to her patient when she was referred to her hospital. Over to you.
Okay, thank you. Okay, as we can see here, this is a transthoracic echo which was performed at our clinic and severe impaired function with well-functioning aortic and mitral valve prosthesis. And then actually the surgeon at this time was to go for IV pacing with defibrillator as the patient had resting left bundle branch block with first degree heart block and severely impaired function, and he is relatively young, so that's why we decided to go for CRTD. Okay, as our protocol in Aswan Heart Center, we are getting the accesses using the venography to access the axillary vein. We are injecting first contrast. So if we are working on the left arm, we are injecting contrast, and then we can visualize the axillary vein. And then if it's suitable, we go for opening the pocket and then getting the accesses from the axillary vein to get three punctures there, one for the coronary sinus, one for the right atrium, and one for the defibrillator lead. And then, as we can see here, usually we start with the coronary sinus lead implantation. I know that in Europe, they are starting with, or most of the centers are starting with the implantation of the RV lead to avoid heart block because the patient has resting left bundle branch block. But actually, in our center, it depends on the indication for pacing. So, if I have a patient who is indicated for CRT for pacing, so I can go from the start by implanting the RV lead. But if the patient had the CRT for resynchronization, so I put the coronary sinus lead first because if there is any problem in the coronary sinus and I couldn't put the coronary sinus lead, so I wouldn't be able to buy V basing to go for buy V basing for this patient. So at this time I will abort the procedure. So we start usually with the coronary sinus. So we introduce extended hook introduction sheath at this sheath. It is 8 French into extended hook. And then we cannulate the coronary sinus using usually a decabular catheter, decabular EB catheter. And then when we cannulate the vein, we are introducing the sheath in and then back with the catheter and start injection of the coronary sinus to visualize the tributaries of the coronary sinus. Actually, as this, sometimes we have to inject after balloon inflation at the distal CS for better visualization of the tributaries, but in other patients we can only inject, and if we saw a suitable posterolateral branch or posterior branch, we can go for it as in this case. And then after injection, we choose the suitable tributary for the coronary sinus, and then usually we use coronary decabular. Sorry, we use quadra coronary sinus lead. Okay, now I can. Okay, now I can move it. So we can use quadra lead. Actually, quadra. Added a lot of benefit in patients with CRT, so it gave more option. It gave more option for basing. So we put quadra in most of our patients, and then we implanted the defibrillator lead as a RV, and then we implanted the right atrial lead. So it was a final picture with the mitral and aortic valve replacement and atrial lead in position as the right atrial appendage, and defibrillator lead in the RV, and quadra coronary sinus lead in the CS. Actually, and this was the X-ray after pacing, and actually the ECG actually was very interesting after that. So after programming, we could obtain this narrow complex with a small R wave in V1 and a small Q in lead 1 and AVL. So we have evidence of bi-V pacing. And actually, after this time, the patient had smooth post-procedure course. He was discharged on anti-failure treatment, but he was compliant with medications, and he is coming every 6 months for programming of the CRT. During the follow-up, the patient has had marked improvement of the dyspnea. Now he has exertional dyspnea class 2. for sure on medical treatment, and he could tolerate the up titration of the anti-failure treatment. So we are now on in Entresto 50 milligram twice daily. We are on carvedilol 12.5 milligram twice daily, besides the exomide and spironolactone and the remaining anti-failure treatment. The patient had no improvement in the ejection fraction, but he had improvement in the functional capacity. So now during the follow-up, he is significantly better than the previous condition. And thank you very much. This is our team in Aswan Heart Center.
Okay, thanks very much. That was a very good outcome for your patient. Mohammed, I see you back. So I just wanted to just to ask you again from your comments from Kenya regarding the management of this patient with regard to the CRT aspects from Kenya, just similarities and differences that you have there.
Thanks. I sort of joined just as the discussion around the access to the coronary sinus was raised. I could see that it was a defibrillator, CRT defibrillator, that was implanted. And again, most implants nowadays in Nairobi are probably CRT defibrillators. We still retain a few CRT pacemakers for the non-ischemic group and for patients specifically who are unable to afford therapy. In Kenya, the National Health Insurance Fund will support about, say, a maximum of 2/3 to 3/4 of the actual total cost of the implant. So patients still have to access treatment, which means that we need to be very careful about keeping the cost of the implant down. In our institution, and probably across Kenya, in Kenya we have one fully trained electrophysiology consultant, which means that everybody else who's doing CRT has approached it either from a pacing angle, a conventional pacing angle, or from an interventional angle. So we use myself, I'm sure Dr. Ngunga and many of the other implanters will adopt coronary tools and techniques to get access to the coronary sinus. So probably we would use an Implant catheter. We might use an extended hook, and then we'd use interventional techniques in order to get into the branch, including coronary guide wires, which I'm sure are also being used by the electrophysiologists. I heard the use of a deflectable sheath, an Agilis sheath, which is not available, at least accessible in Nairobi. But somehow, our implant success rate is close to 100%, if not 100% over the last 5 years, without using these more expensive and fancy tools. I think there was another comment that sprung to mind, but it's dropped out. So if I remember it, I'll come back to it.
Okay. Yeah, I think maybe we should just spend a few minutes more on the access of CRT in Africa. And, we were involved with a survey that we conducted as part of the AFRA project a few years back. And the number of CRT implanters in Africa is actually very, very, very low. Usually confined to a few centers in a particular country, barring a few countries. So I just wanted to find out now, in terms of, it seems like access to CRT in Kenya is at least in Nairobi is available. What about other cities in Kenya? Is it do they refer through to Nairobi, or will a patient not receive CRT if they live elsewhere?
So there are two cities. Again, we talked about the referral pathways being challenging. Mombasa is the other city. There are 2 cath labs there. And I think 2 implanters across the 2 cath labs who can comfortably, independently perform CRT implants. And so after they've opened up that, about 4 or 5 years ago, the access increased. The truth is actually that in 2012, there were CRT implant in Nairobi itself was actually at a very, very low rate. It required, at that stage, I think there was one implanter at the time, and most of the implants were done through visiting EP camps. Some of them humanitarian, and some of them not. And as you mentioned rightly, the African Heart Rhythm Association surveys have indicated a transition from these sort of supporting groups to a proctorship-based model, and then eventually moving into a sort of independent practice. And many of us, yourself, I'm sure, Professor Mirvat and others have been across Africa proctoring CRT specifically, such an important therapy. And that's improving access in small steps.
Right. And Dr. Kamal, from your side, is CRT now readily available across Egypt?
Yeah, in Upper Egypt, for example, it's available in each city. We have a center for CRT implantation. We have 1 or 2 implanters for CRT. In Cairo, we have like maybe 3 or 4 centers, or maybe even more for CRT implantation. Also, it was a great step from the government to cover the CRT in insurance. So, if the patient has insurance, so he can be referred to the insurance and with a medical record that he need for CRT, and then the insurance will cover the cost for CRT. But you know that in Egypt, it's not all people are having insurance. Like in Europe, we don't have insurance for every patient in Egypt. But we have, like Aswan Center, we have a charity center. So we have charity centers in Egypt, like Aswan or university hospitals. In Aswan, for example, we are a charity center, and we are covering the cost of the CRT for such patients. So the patients will have CRT at our center for free if he is indicated. And in university hospital, it was like depends on some papers for the patient to and some steps to follow, and then he will the cost of CRT will be covered with the university hospital. So either insurance or university hospital or charity centers. So I think it's much easier now for the Egyptian patient to get an access to CRT implantation, and we have growing number of implanters across Egypt, in Upper Egypt, in the capital, in many cities in Egypt. We have many implanters. So I think it's getting easier in Egypt now.
Okay. No, thanks for that. I'm going to go to the chat line at this point, and Dr. Ngunga, has anything come through on the chat line?
Yeah, a couple of questions here, Dr. Chin. So I think there's somebody from Ethiopia. They want to know when doing the CRT, Dr. Kamal mentioned putting the LV lead first, and kind of if maybe Shidai may get a good choice, then she can go ahead and continue putting the RV leads. But from some other doctors, they prefer to put the RV lead first, kind of so that they don't dislodge the LV lead when probably they are putting the RV lead. What would you advise? Maybe centers, maybe you are probably very experienced, but what would you advise people who are not very experienced putting CRTs in some centers? Do you think they should follow your strategy, and then maybe as they get more confident, they don't have to fear dislodging the LV lead when they are putting the other leads?
Yeah, I think it's an option to have the dislodged lead after implantation, and also for the beginners in CRT implantations, I advise every operator to start with the RV lead, because those patients have left bundle branch block. So during manipulation, you may cause right bundle branch block, and then the patient will have complete heart block. That's why it's more safe for the patient to go for the RV lead first. But as I mentioned, that the protocol in our center and my protocol actually to go for the coronary sinus, because if I blunt the RV lead and then the patient will not, we couldn't get an access to the CRT. Yeah, it's a real situation, but it happens. So so I can stop at this point without opening a new lead, and but to be safe, I think that the most suitable to start with the RV lead, and then you can go for the corner sinus lead. If I started as our protocol with the corner sinus lead, I go for the good fixation of the corner sinus lead, peeling and fixation of the lead, and then I am securing my lead using fixing it away from the other one, and putting the other one cautiously. But yeah, there is a risk of dislodgement of the corner sinus after with the implantation of the RV. So depending on your protocol and your experience, you can go whatever you are comfortable for. But I guess for the safety, you need to go first with the RV lead. Yeah.
Thank you for that question. Some other question coming, I think is coming to someone from Kenya is asking. I think maybe Dr. Jalen can tackle this regarding this defibrillator, the CRTD. Kind of more studies showing that there's less and less use of the defibrillator aspect in this for some of these patients than ischemic cardiomyopathies. Like, for example, this particular case. In resource limited areas, and maybe we can get some perspective from Egypt, where you put probably more defibrillator than even Kenya. What is the use? Have you done an audit to see how many of these CRTDs, particularly when they come back for device change, require? If they have never used the D, for example, do you still believe in using the D for all patients, or do you have a system of kind of deciding who will benefit from the D, and particularly if the finances are an issue? How would you advise some of the doctors who are kind of making these kind of decisions in day-to-day life?
Okay, let's talk about our protocol here in our center. For the patient with ischemic cardiomyopathy, we are going to CRTD if it's available. And for the patient with non-ischemic cardiomyopathy, we are doing cardiac MRI for them. If the cardiac MRI showed extensive fibrosis, so we can go for CRTD if it's available. If there is no fibrosis or minimal, that we can get like septal fibrosis, minimal septal fibrosis, so we can go for the CRTB. But in some patients who are younger in age, so as this patient is 50 year old, so he's so young. If I have CRTD available and he has non-ischemic cardiomyopathy, and if I have CRTD available, we go for CRTD, not for CRTB. But as a general rule, we are going to CRTD in ischemic and CRTB in non-ischemic, except in patients who have either VT before as a secondary prevention, or they have extensive fibrosis in their cardiac MRI, so we can go for CRTD. But as we know that there's now decreasing evidence about the benefit of the non-ischemic population from the CRTD, and that it didn't differ as regards the total mortality, but till now we are sticking to the same rule in our patients here.
Thank you very much. And now, question: if you still have appetite for more questions, Dr. Kamal. Looks like someone is very active here. George is asking again about, is there real evidence for his bundle pacing over the traditional LBB pacing? Or is this just a physiological chase for his bundle pacing? Is there real evidence for it? And do you think doctors should chase his bundle pacing?
Yeah, I think it depends on the ability of his bundle basing to correct the left bundle. So you know that we have his bundle basing, but we are selecting the patients who are candidate for the ability of his bundle basing to correct the left bundle. We know that it's lower than the his bundle in other populations. So the ability to correct left bundle, it's a great issue in his bundle basing. So in such patients, actually, we are preferring to go for CRT because we tried before to correct and using his bundle in such patients, and we couldn't correct the left bundle in a significant proportion of our patients. That's why we decided to go in left bundle basing in the left bundle branch block patients to go for CRT directly. And if the patient has no access for the coronary sinus or whatever the cause, so we can go for his basing in the patients who are not candidate to have coronary sinus lead. But till now in those patients we are starting with CRT implantation, and then we are if it failed or something happened, we couldn't access the corner or whatever, so we can go at this time for his pacing. But the outcome of his pacing in correction of the left bundle, it's a little outcome than expected, if I can say that. Yeah, I don't know if Professor Chen has experience in this. Yeah.
Yeah, I agree with you. I think I've been using the HIS lead for when the CRT, when the LV lead is challenging, and it's a bit of a hit and miss in terms of whether you can get left bundle branch correction. I know the data in the literature says around about 70 to 80%, but my experience, I think it's probably less than 50% that you can narrow the QRS and get selective or non-selective or selective HIS bundle capture. I think the other thing is with his pacing is that it's sometimes the threshold is quite high, and you might have to pace at very high outputs to get his capture. So which is obviously a problem in terms of battery longevity. And then there is a dislodgement rate. I mean, these leads sometimes can dislodge. Left bundle branch area pacing, I've got limited experience in that. But I think it's where the field is moving now, and I think is sort of I think it's a technique that I think is going to be very useful, because I think if you from the provisional data that's available is that you can the thresholds seem to be better, the lead tends to be a bit more stable, and you can capture the left bundle in slightly higher, or correct the left bundle branch block in a higher percentage than pure HIS pacing. So I think it's a technique that I think is probably going to be an important one going forward. I think if you do get HIS bundle capture with a narrow QRS, the ECG looks very good, and it just looks pretty, right? And I think just from my anecdotal experience is that I think the patients tend to do very well if you can capture the HIS and narrow the QRS.
Yeah, I agree with you, Bob. I agree with you.
I find it interesting that CRTD is so commonly used in Egypt and in Kenya, because in South Africa or at least we are working mainly in the state sector, is the cost of the device is sometimes quite is obviously still high. So we tend to put in quite a fair amount still of CRTP devices in, and potentially leave the D if someone with some additional criteria, like you say, maybe a bit more scarring or more PVCs, or a younger patient with a more poor LV function, we could consider putting in a CRTD for primary prevention. But our practice here in Cape Town, at least in the state sector, is still largely one of CRTP as opposed to CRTD.
I think it's related also to the funder, whoever it is that's funding the therapy. So often in a private institution like ourselves, and also with a rudimentary insurance structure, national insurance structure, a decision, we've got such a small number of implants that the total dent and the difference is a little bit negligible. Remember, NHIF in Kenya will probably pay a total of $7,500, and an implant on average will be for CRTD would be somewhere in the $11,000 to $12,000 range. So there's still a deficit. So often when we have the discussion with the family and the patients, we're relatively honest about what could be achieved by the difference between a CRT and a CRTD, and we leave actually that discussion and the decision with the family. And in Kenya, we have this system called the Harambee system, where families can very quickly engage a whole pool of well-wishers and close relatives and friends, and do fundraising to support these initiatives. And it's it was astonishing to me how people from very, very poor indigent background could mobilize resources so quickly. But you're absolutely right. In a more organized system where national resources are accessed and the ministries have got their eye on it, it's very difficult to convince people to pay the extra difference.
Right.
Yeah, that's why I believe it's mandatory for all the countries to have insurance for all the patients, because this problem will be there till that the insurance should cover everything to our patients, because you know that if the patients have money and the other patient doesn't have money, and this patient have a nearby charity center and this patient doesn't have. So I think insurance should be accessible for all the population in our country. That's the solution for the level of economic status as Egypt or Kenya or whatever. So I think insurance should cover the whole country. Yeah. I think there's a solution. Yeah.
A more pertinent question, perhaps, is it's much easier when you're already trying to improve the patient's cardiac function with a resynchronization therapy device, and there's an anticipated gain. And there's certain sort of cardiomyopathies, maybe alcoholic, hypertensive, peripartum cardiomyopathies, where you may have a much greater likelihood of success with CRT than, say, chemo-induced cardiomyopathy. And in those sorts of groups of patients, you can sort of approach it with thinking, well, maybe I'll be able to do something. But in patients who don't need CRT at all, and you have to make that decision, am I going to implant an ICD or trust medical therapy and hope that the patient improves? I think that's a much more difficult decision, because, it's either something or nothing. It's either an operation or no operation. Once you're doing an operation, it's much easier. Technically, it doesn't make a big difference to the patient.
Yeah, coming back to this patient, this patient has a patient like this would not be involved, wouldn't have been necessarily enrolled in CARE-HF, the landmark CRT study, because the patient has essentially a valvular cardiomyopathy. And I think in Africa, in developing countries at least, or low and middle income countries, we probably see a bit more of patients post-valve replacement where their left ventricular function is very, very poor because of rheumatic heart disease and delayed access to surgery and valve replacement. So, I think we haven't looked at specifically this at our institution, but my impression is that these patients with so-called valvular cardiomyopathies respond quite well to CRT, pretty similar to the dilated cardiomyopathy group. I don't know if that is similar, your experience where you guys practice, but I think the valvular cardiomyopathies with left bundle branch block do quite well with CRT. Is that your feeling as well?
Yeah, but we don't have a large cohort of patients with valvular heart disease who are undergoing CRT implantation. But for the number we implanted, they have a good outcome. But I think it's not as good as the dilated cardiomyopathy without valvular. Because some of the problem is, or part of the problem is the post-surgical sequelae, because surgery and redo surgery, and it causes a lot of fibrosis in the myocardium. That's why these patients, I think, part of the impaired ejection fraction is related to the presence of fibrosis. That's why I think if the patient had many surgeries, or one or two or whatever, I think they may respond less than the patients with dilated cardiomyopathy who didn't have any surgery before. As I said that we don't have a large cohort of those patients, but another thing may help in improvement of these patients is those patients who have left bundle branch block are improving with CRT more than the patient who doesn't have. It's just like we notice this in our patients. Maybe because of the first degree heart block itself, it causes like diastolic valvular regurgitation, and it causes like some sort of diastolic dysfunction. That's why in patients with left bundle branch block and the first degree heart block, Actually, we predict that with biv pacing, first we will control the pacing, because we will shorten the AP delay, and then the CRT will have the upper hand. And the second thing that in those patients is the correction of first degree heart block, in addition to the correction of the left bundle branch block, add a lot of benefits for the patient. So I think those patients, especially, they will get benefit from the CRT more than the patient without the first degree heart block. I don't know your experience, but we noticed that in our patients. Yeah.
I would 100% agree with that, and I also agree that if you've got first degree AV block, that kind of trumps a lot of the other decisions. So, for instance, in patients with right bundle branch block, if you've got first degree AV block, a very prolonged PR interval, more than 230 or 240, those patients will get better atrioventricular synchronization. And actually, when you look at the data for hemodynamic improvements, when you're trying to optimize these devices, most of it actually comes from the AV resynchronization, much more than it comes from resynchronizing the two ventricles or within the ventricle. So I'd agree with that. In terms of my experience with valvular heart disease and resynchronization, I'd agree with Prof. Omnia Kamal that this is less. I'm not that impressed. My experience has not been as impressive as for the dilated cardiomyopathies. I think a lot of patients with valvular heart disease, certainly in our country, their ventricles have been stretched for a long time, and it probably is going to take a lot longer for their ventricles to improve. Certainly, I've never seen a super responder to CRT following CRT implant in a valvular case, except, the one scenario where you might get a benefit is a very unusual scenario for Africa. A patient who's had a TAVI, who has maybe a weak ventricle, and after TAVI, they go into left bundle branch block and heart block. And those patients, if they get a CRT, you'd anticipate a much better improvement. But people with burnt out valvular heart disease in Kenya, they don't do so well compared to the dilated cardiomyopathies.
No, absolutely. I think what I meant was that I think we wouldn't not consider CRT in them, but their response is less than a dilated cardiomyopathy because of their structure. Often the ventricles are bigger, and they don't typically necessarily have left bundle branch block. So, but I think it's illustrated in this case. I think it's an important modality to offer that patient a CRT, because other than transplantation, there's not much other, besides optimizing some medical therapy. But in terms of CRT, in this case, it worked very well. So I think we've lost Dr. Ngunga on the chat line. So I don't know if are there any other questions that any of you have for each other before I summarize, because I think we're approaching the end of the call now. It's gone so quickly. I submit we've only got 3 minutes left. So maybe what I will do then is I'll just summarize our webinar today in the last 2 minutes or so. I think it was really an excellent case of a patient who presented with rheumatic heart disease, a disease that's common in low and middle income countries, and it's a case that I think we chose because it's not an uncommon scenario that patients have delayed, for multiple reasons at various levels, have delayed referral patterns and systemic issues to optimal medical care. And I think this case illustrates quite well the difficulties that different countries, or in this case Egypt, has in referring a patient to an expert center where valve surgery can be performed, and then later on where CRT can be performed. And it also illustrates the importance of compliance and the need for ongoing penicillin prophylaxis to prevent recurrent bouts of acute rheumatic fever. But I think it also it highlights an important case, because it illustrates that even in patients who have so-called valvular cardiomyopathies, there are options in patients with left bundle branch block, and these patients should be considered for CRT. Even though the response rates might be lower than your conventional ischemic and non-ischemic cardiomyopathies, these patients may do well if they've got a typical left bundle branch block. I think in the second half of the presentation, we touched on access to CRT in Egypt and Kenya, and it seems like this modality, at least in our 3 countries now, is becoming readily available, and is an important treatment modality that all cardiologists should be aware of. We touched on the tips and techniques of LV lead implantation and basic CRT implantation, and I think that's probably a topic for another day. But Dr. Omniak nicely illustrated some of the techniques involved. And then lastly, just the differences in practices. It's always nice to know, just practices in CRT-D versus CRT-P. I always thought that CRT-P was more common in Africa, but it seems like, at least in some countries, CRT-D is still very commonly, is more frequently used. And then I think just lastly, I think we at his bundle pacing and left bundle branch area pacing is a space to watch out for. And I think maybe in a year or 2, I think that's going to be a topic of interest at these PCR webinars, and the techniques of left bundle branch area pacing, I think probably the more than his bundle pacing. So I think that's my summary. And I'd just like to thank again the faculty, the distinguished faculty today, and I'd like to thank Dr. Kamal from Egypt for a presentation and the discussion points, and then Muhammad Jaylan from Aga Khan. Thanks again for your input and your commentary there, and Dr. Ngunga, who we've lost unfortunately, but for his contributions for manning the chat line and for his insights from Kenya as well. So we just like to thank you again for your input, and just hope everyone, wherever you are in the world, enjoyed this webinar this evening. Thanks very much.
Thank you very much. Thank you. Thank you very much. Have a nice day. Thank you.